All right. All right. So, hello. It's very nice to meet you. Can I just call you Renee?
Yeah.
All right. So, how long have you been in OT for?
Oh man. This is my 17th year
Oh, wow.
practicing.
Oh, wow. That's impressive. Have you always been in acute care? I know, Dr. Alan Tasha mentioned that you also do like work in the ICU as well.
Yeah, so I actually, oh my gosh, I've had quite a lot of jobs actually. I started out actually in inpatient rehab when I graduated. Excuse me, and I remember being terrified of acute care. Um, because anytime the rehab unit's slow, they send you over to acute care, and I just remember being terrified. Um, then I switched over to I've done long-term care, I've done subacute rehab.
Oh, wow.
I've also done a little bit of home care, but not full time. And then no, I mean, I'll be honest. I mean, I think I always wanted to work in a hospital, but it was just kind of the right place, right time, and I am going on 10 years at my current job, so
Oh, wow.
something must be
So,
good.
wow. So you really seen it all. You got a big spectrum of like the OT. What like really drew you into like having acute care be like your main um setting for the last 10 years?
Um, hmm. Well, like I said, it was just kind of the right place at the right time, and I just went for it. And I don't know, it's like you never know what you're gonna get. You see something new every day. You encounter so many different kinds of people that it's just, I don't know, it keeps it interesting.
That's really cool. So, when you mentioned like you like something new every day, like do you like see patients more than once or is it like you like get different patients every single day?
It depends. It depends what they're in the hospital for. Um, we have I don't even know, there's probably about 8 or 10 different floors. They try to keep like, say cancer patients on one floor and orthopedics on one floor and neurology, neuro stuff on one floor. But sometimes, it's kind of like all over the place depending on, um, what comes in. And, depending on staffing, I mean, I go everywhere. I go to the ICU, I go to the cardiac critical care unit. I used to live in the emergency department and do evaluations down there. That was kind of back when, not back when, because it was more recent. When they would hold a lot of people down there because there wasn't room in the hospital.
Mhm.
So then therapy orders would sit down there for days. So we were asked to go down, and I went down, and I loved it
Oh,
because
oh
it's just
wow, that's really cool.
chaos. Yeah.
That that actually leans into one of the questions I had was like, do OTs in your hospital like go into the emergency room for like treatment?
So we did for a while.
Mhm.
But due to like staffing and like productivity, they basically kind of determined that it was kind of, I don't want to say a waste of time because it definitely wasn't a waste of time, but it was a time suck. Like it would just, you were down there and seeing patients that either really didn't need to be seen, like could have waited till they got to the floor,
Mhm.
you know, been admitted, because sometimes they're there, and they're under what's called like observation status. So like they're too sick to go home, but they can't really get, I guess, like a billable diagnosis to keep
Mhm.
them
Okay.
in the hospital. Yeah. It's all
Mhm.
insurance.
Yeah.
You've
So
probably learned about that.
yeah, we're learning it right now. It's not a fun process.
Yeah.
Um, so how long are you typically in a room with the patient when treating them?
It could be anywhere between 15 minutes and 2 hours. It really just kind of depends on. what the patient needs. I mean, obviously, like the higher acuity, diagnoses, or like if they're in the ICU, those generally take a lot longer.
Mm-hmm.
Um, because they have a lot of lines, like IV lines and cardiac lines and all kinds of
Yeah.
stuff. So,
Mm-hmm.
some are vented, they're on higher, like really high levels of oxygen, that
Mm-hmm.
kind of thing. So,
That's so
yeah.
interesting. Is there
Yeah,
like,
now on
oh,
inpatient rehab, now is this just acute care?
yeah, well, we
Oh,
are each
okay.
assigned a different setting.
Okay, never mind. I won't say anything then about inpatient rehab. That's good. Uh,
So is there like a particular like diagnosis you see the most, or is it kind of like all over the place when it comes to diagnosis?
oh man, it's all over the place.
Mm-hmm.
Um, yeah, I mean, we see anywhere from like general medical, they come, or like they come in just feeling ill and they end up, you know, finding things to, you know, work up and all that kind of stuff. We have a lot of, we see a lot of surgeries, a lot of like orthopedic surgeries, hips, shoulders. I actually had one today that had rib plating.
Wow.
They like broke their ribs, and yeah, they ended up having to put plates in the ribs to stabilize them.
Oh wow, I have
They actually
never heard
did
of
pretty
that.
good. I was kind of shocked.
Oh wow.
But yeah, I mean, you know, we get a lot of, because we're in Pontiac, we get a lot of, low income
Mm.
people that like don't see a doctor regularly. And so it's like when they come in and they're sick, they find a whole slew of problems. And
Uh,
yeah,
can you walk me through like just like a general day? I know you said it changes every day, but like what would be a typical day like?
yeah, I just, we get to work. We have somebody that's assigned to do like the acute care schedule. So for all the OTs that are there that day, that they take, we take those, and then we kind of look and see how many people we have on our caseload. So, the evaluations get scheduled first because, those come through, and we like to try to get to those at least within 24 hours.
Mhm.
Um, and then the treatments just kind of get scheduled from there. And, I don't know, we get scheduled with probably about, I would say, anywhere between 12 and 15 people a day.
Oh,
Um, no, but I only see about seven,
yeah,
maybe
because you said like the
8, 9,
varying
10 on a
times.
good
Yeah.
day. Like, yeah, it just kind of depends.
Mhm. Yeah.
Um, and I mean, we're all over the place. So,
Hmm.
because Trinity Health Oakland is a stroke certified hospital, we have to prioritize the strokes. So anybody
Hmm.
that comes in for stroke like symptoms, um, yeah, so all the neuro stuff, all the surgeries, we prioritize like the heart surgeries as well.
Yeah, you mentioned the cardiac side.
Yeah, just to get them up and moving because it
Hmm.
shortens the length of stay generally.
Hmm.
So,
Yeah.
yeah.
Mhm. So speaking of like discharge and like length of stay, does your hospital like allow like the therapist to like have like a say in for a patient to get like discharged to like another setting or to home?
In a way, yes. We can't actually say like, oh, we think they should go, or I shouldn't say like we can't put it in the documentation where we think they should go. We can just say like, yep, they need more therapy before they can go back home, or wherever they're from, or their prior level of
Mhm.
function.
Yeah.
Um, only because, if insurance, here we go with insurance again.
Hmm.
If insurance looks at it, and says, oh, well, the therapist is recommending, say, I'm trying to think of what would be, like subacute rehab, but really they'd be a good candidate for inpatient rehab.
Hmm.
They're going to say, well, because subacute rehab is a higher level of care,
Yeah.
technically, in a way, more expensive. I mean, I guess, you're in the hospital, but um yeah, so it's kind of, it like, we basically just don't want to say where they go just because, the insurance can say, well, yeah, well, you said this, but this
Yeah.
is cheaper. You know what I
Mhm.
mean? That kind of thing.
Yeah.
Um, if we feel really strong, we'll go, like I'll go and talk to the inpatient rehab case managers and I'll say,
Mhm.
hey, really look into this patient. I think they'd be a really good fit, yada yada yada. Or, I'll tell we'll tell like the case managers, yeah, they'd probably be better for, subacute rehab, or no, they could go home as long as maybe they have a little bit more help. But, we can't actually document it
Yeah.
that way in the chart.
Yeah. You kind of like
Essentially.
have to use like keywords to like make them be like,
Yes.
maybe we should consider it.
Yeah.
Mhm.
Yeah.
So
For
like
sure.
kind of like on like that topic of like other like team members, not necessarily just like other settings, but like as an OT, it's kind of been known sometimes that you could be overlooked because everybody's like, I already have a job or what is occupational
Oh yeah.
therapy. So
Oh
like
yeah. We get
when
that a
you're like
lot.
talking to like other team members, like how do you like make OT stand out and make it like I'm sorry, I'm trying to rephrase this. Like make it valuable in the healthcare setting and for the patient.
Yeah, that is a good question because I don't really feel like I ever have to like fight for my job and what I
Hmm.
do and
Yeah.
explain why it's important. Um, because yeah, I mean, I'll frequently I'll just get called, oh, it's physical therapy. I have the physical therapist in here, and I'm like,
Hmm.
sometimes I'll say, no, I'm occupational, and then they'll
Hmm.
say, well, I don't need a job, and then that's when I have to go and explain,
Yeah.
what I do. It's skills for the job of living.
Hmm.
You got to be able to get dressed and go to the bathroom and do all the,
Hmm.
and then they're kind of like, oh yeah, like, like, oh yeah, I do need you type thing.
Hmm.
But
Yeah.
yeah, I mean, in terms of like explaining it to like the rest of the medical team,
Hmm.
not necessarily. We've had to kind of, because they'll ask like what some of our notes say, like, well, what does this mean? And, we'll have to like, explain that, but that's really about it. I've never really had to, you know, tell anybody else on the medical team why OT is important,
Well, that's very good. That's
which
very
is
good.
good. Yeah, you're right.
Yeah.
Yeah. Come
Hmm.
to think of it, that's a good
Yeah.
thing.
It is a great thing. So going back to like documentation, is there like a set time you're able to complete your documentation, or do you like gather notes through the session, whether it's like you write them down or you just like make mental notes what you should put in?
Yeah, I mean, ooh, yeah, that's a good one. So our productivity standards on acute care are not nearly as high as inpatient rehab.
Hmm.
Um, so we have to essentially get 75% productivity throughout the day. Um, and I don't, I actually sometimes think that's too high, but, because, there's a lot of people, they're gone for tests or they're at dialysis, or it's like, and you got to factor that in. I mean, I've had days where I attempt 20 some people and I only see like 7, so I mean, it really, some days I can hit 75%, a lot of the days I can. It really just it really just kind of depends. um but go back to your question. What was your, I kind of got sidetracked.
So like when you're doing documentation, like do you take like notes or like mental notes to like help you remember or like making sure you're getting
Yes.
key points?
Yeah, okay, so we can actually factor in some of that, like the chart review time
Hmm.
and the documentation time, into our billing for the patient. So I mean, I try to not, if I get sidetracked and I'm talking and talking, and it's taking me, 30 minutes to type up an eval, I'm not going to bill for that,
Yeah.
clearly, because it's
Hmm.
my fault. It's not, you know what I mean?
Yeah.
So I mean, I'll generally maybe do 10 or 15 minutes,
Okay.
But most of the time, yeah, I mean, I'm in with the patient for, you know, most of the time that I bill.
Mhm.
Um, but yeah, I mean, because, we have to know about the patient. I mean, I need to
Yeah.
know, the
Mhm.
precautions, and I just try not to spend a lot of time. I go in and I get what I need from the chart, and then I, go and treat the patient.
Yeah.
So,
Mhm.
yeah.
How long do like patients in acute care like stay? Like what is their length usually?
Oh man, it could be anywhere from, I mean, we have somebody on our caseload that's been on there for over a month. I mean, it really just depends on what they come in for and how complicated,
Mhm.
their hospital stay is. Um, Generally, I want to say anywhere between like 3 days to like seven, but then, you get those outliers where
Yeah.
it's like they're there for a day or they're
Mhm.
there for a couple months, it really just kind of depends.
Mhm.
Um, I really don't understand why people stay so long if if it's not medical, like I know we have a couple people there that have like housing instability
Mm.
I've seen. So like I think they're just trying to, you know,
Mhm.
find a stable environment.
Yeah.
Oh,
Yeah.
yeah. So
So like do
sometimes they
most
need notes because if they got to go to like a rehab,
yeah.
then
Mhm. Yeah.
they need
So
updated notes from therapy. So
yeah. So do like more than one OT like see the same patients? Like are they kind of just like going through like every day, like maybe like a different OT, or do you usually get the same caseload?
that again depends on like staffing and like how
Mm-hmm.
many evals are on each floor and all that, and who's like there that day.
Mm-hmm.
Um, no, I mean, we only see people once a day,
Mm-hmm.
but it's not like we're not necessarily on the same unit every day,
Okay.
if that makes sense.
Mm-hmm.
So,
Maybe.
yeah.
So, since being in acute care for almost 10 years, like have you seen like major changes in the system compared to like when you first started?
Yeah, I mean, especially since COVID.
Oh yeah, I can imagine.
I mean, yeah. Yeah, that was a little traumatizing. Yeah, I mean, and all the like legislator stuff, like, I mean, things just change and, there's, the case managers are being pushed by higher ups to get these patients out. So then we get pushed to see them and, all that. It's just kind of,
Hmm.
rippling effect kind of deal.
Yeah.
Um, yeah, I mean, it's definitely changed, for sure. I mean, we're expected to, do more with less time, essentially,
Hmm.
but luckily we have a good boss and she really goes to bat for us. So,
That's good.
yeah, so we don't really see a whole lot of the upper management side of it. We're just told just keep doing your job and, because we all have good hearts, obviously, because we
Yes.
wouldn't be in this, you know, in
Very
this setting.
empathetic I said almost occupation setting for our field of work.
Yeah. Yeah,
Mhm.
exactly.
Yeah.
So, I mean, not just anybody can do what we do,
Mhm.
it's got to be somebody that cares about people.
Yeah. Yeah. So I want to ask you another question. It might be similar to one of my past ones, but I'm just going to get out of the way. It's how do you articulate the distinct value of occupational therapy to the other members of the interdisciplinary team specific to this practice setting? I know we kind of already touched bases on that
Yeah,
a
a
little
little
bit.
bit.
Hmm.
Like I said, I've never really had, when I think about it, I've never had to really articulate why
Hmm.
OT is important.
Hmm.
Now I know, you know, Dr. Allen, I don't know if she's going to end up listening to this, but I know she's very into like the mental health
Hmm.
aspect
Yeah.
of, just care in general. It doesn't even really have to be OT, So I mean, there's like, there's other or not other, I should just say there's a lot of various aspects that can go into OT that make it
Mhm.
important, if
Yeah.
that makes sense.
Yeah. Hmm.
Um, I mean, I really feel like we go to bat for what's best for the patient
Yeah.
too.
It's really good.
Um, but yeah, I mean, ultimately it's up to the doctor and the insurance.
Yeah.
But luckily I've never had to tell my fellow medical staff why we're important.
Hmm.
It's kind of
That's
nice.
really
I'd be curious to know what Dr. Allen says
good. Yeah, I'll have to ask her
about
next
that.
week. All right, just last few questions. What is your favorite part about being like an OT in the acute care setting?
Oh man, you never ever know what you're gonna get, and it's different every day. Every day I see something new, whether it's just on the super gross spectrum or just super wild. Like I can't even.
Hmm.
Yeah, and it's just, I mean, it's every day is different.
Hmm.
It's fun. Never know what you're gonna get.
Hmm. And then lastly, any advice for anybody who's interested in going to acute care?
Ooh, I think you should definitely. I truthfully, I feel like every OT student should do some type of field work, whether it's like a level one. I don't know what they call them now. Is it level one and level two still?
Yes. Yeah.
I think everybody should have to do one. I feel like that's where you learn either that and or inpatient rehab. I feel like you really learn a lot. You see a lot of different, general things,
Hmm.
so then at that point you could branch off to, whatever you like if, there's outpatient,
Hmm.
orthopedics, and then you got your peds. Now I don't see a
Yeah.
whole lot of peds. We do have a NICU.
Hmm.
Um, we have a couple therapists that go down there. I mean, I'll be honest, they scare me. It's just they're so fragile
Yeah.
and it just
Hmm.
makes me nervous. So
Yeah.
it's not my forte. Um, but yeah, yeah, I like it. I don't know.
Yeah. All right. Well, that's all I have. Thank you so much for this.
Of course.
It was really helpful, and yeah, thank you
God,
for
am I on
letting me interview
video
you.
for this too, or are you just recording my voice?
It's on video too.
Oh
Don't
no.
worry. Don't worry. All
Sorry,
right, I can
guys.
stop it.
Just
All right, I'm
kidding.
gonna stop the recording.